Thank you, Susan. I know the DISRIP has been mentioned a couple of times, and I know that's really kind of directing where we're going in terms of the delivery system in this region. And Bassett does cover all of the counties who are involved here at the table. Dr. Anderson or Dr. Johns, would you want to comment in terms of additional treatment availability in the region? Is that being looked at in terms of through the DISRIP process? And what plans may be in the offing there?
I'll take the first crack at this. We are working right now, I think that Dr. Dostal very eloquently talked about the importance of having treatment ready on demand through a short window when a person struggling with addiction is in that period that they are ready and able to accept treatment. With this in mind, and also recognizing, as Sumat points out, that we have a shortage of providers, particularly a shortage of medical providers. Taking those two things together, we are working on building a model of office-based treatment for opioid addiction, opioid and heroin addiction, specifically trying to set up not just getting our physicians set up with an X license, which is absolutely essential to be able to prescribe Suboxone, but certainly not sufficient. But making sure that entire clinics are prepared, from the physicians to the nursing staff to absolutely having behavioral health available. It is medication-assisted treatment. It is not just treatment with medication. So having counseling available in addition to prescription medications like buprenorphine, like Suboxone, are essential. We are working right now on, knock on wood, we are working on a proposal with some of our colleagues over in Massachusetts to be a part of a large national grant that would give us funding and training to set up this infrastructure in a number of our primary care clinics. That's down the road. That's aspirational. That has not happened yet. We are working towards it, but that's our goal. In terms of what might be helpful to move this effort forward, not only this specific effort to build a program for medication-assisted treatment, but our overall goal of trying to make a significant impact in this epidemic. There are a couple of things that I have identified that seem as though they might be useful. We mentioned that in order to be able to provide Suboxone, we need medical providers that are willing to do it. Well, certainly they have to be willing to do it. They also have to be legally allowed to do it. As it stands right now, a provider can provide this is a little bit of hyperbole. There are very few barriers in terms of how much hydrocodone, how much Percocet a provider can prescribe. When a provider wants to try to deal with this problem, that I often say that we in medicine have been benevolently complicit in its creation, we have to jump through hoops in order to be able to get access to this medication. We have to go through, I think this is a wonderful act that it's available. We have to get a data waiver, the Drug Addiction and Treatment Act, in order to get an X number to be able to provide Suboxone. So that's doable, but that creates an extra barrier for already very busy providers to even have the option on the table to use this medication as a part of treatment. So that's one barrier that I suggest that we might look at. Even with the data waiver program as it is put in right now, our physicians are eligible to get that waiver. Our advanced practice clinicians, our nurse practitioners, our physician assistants are ineligible to even get into a position that they are able to provide Suboxone. That is a potential barrier. It seems that having it be more challenging to provide the medication to treat addiction than the medications that down the road for many of these folks are leading to addiction, that's a problem. And I guess the last thing that I would say, particularly as we are looking to expand these office-based treatment centers for medication-assisted treatment, one thing that we are very cognizant of as we are setting these up, making sure that we are not only helping our patients, but we are in compliance of the law, is looking at CFR 42 Part 2, which governs record keeping as it pertains to substance abuse treatment. The law was put in place with absolutely important intentions. We know the stigma that is around addiction. This law is put in place to protect the confidentiality of patients who are going forward to get addiction treatment, and that's absolutely essential. But as we are building these office-based, these primary care-based medication-assisted treatment programs to meet the need that we know that is there for on-demand treatment, for treatment in a short window, for bringing treatment to where patients are at, we have to make sure that we have clearly written legislation that lets our providers know that as they do this important work, that they are safe from legal repercussions, while also making sure that patients are assured that their records are not being widely publicly available. I don't know if that's what you folks were listening for, but thank you for bringing me here.
Yeah, could you repeat that legislation, the chapter number? Is that federal or is that state?
So,
it's federal?
Yes, federal. It's CFR 42, Part 2. The other law that I referenced was the 2000 Act, the Drug Addiction Treatment Act, or the DATA Act, which allows the use of Schedule 3 to 5 drugs for treatment of addiction.
Okay.
We mentioned you've been mentioning medication-assisted treatment. That would be you're referring to outpatient treatment.
Yes, Senator.
Is there any plans in terms of inpatient treatment options in this region?
I think the issue with inpatient goes back and goes back to the payment for it. I mean, we've had this discussion. Why don't we have some local beds? And the issue is sustainability as well as the availability of the medical staff to work with the inpatients. There are conversations that go on pretty regularly about this because we do have some empty beds locally, and we've talked about what we can do about them. But they have to be sustainable. You know, hospitals shouldn't have to take a loss to provide this service.
I know, Dr. Johns, I know you wanted to speak to that.
I think I was actually going to say very much the same thing, that what we would be reimbursed for doing, it would be a critical question. You know from the past that just sustaining a psychiatric unit in this part of central New York costs more than we get reimbursement for. There is not reimbursement for inpatient detox in a medical hospital such as Bassett, and there is very specific skills and training that go into doing both detox and rehabilitation, particularly inpatient rehabilitation. The long and short of it is that the availability is not sufficient in our area on any level. And certainly if we make it through that part, if someone with an addiction problem makes it through those steps, there is still not at all enough long-term outpatient maintenance treatment. And I did want to say at this juncture that we need to recognize that we are dealing with a chronic relapsing illness. I deeply believe that we need to have effective medical treatments. I believe that that includes Suboxone, Vivitrol, many other agents that we can use, and abuse. I know that my law enforcement partners don't want to see a lot more Suboxone flooding the streets, and so I also deeply believe that the treatment that we give has to be done very carefully. It has to be done with support services, including counselors, and then that comes back to your question, are we going to be doing it in the hospital, or are we going to do it in our medical center? We're siloed. Most of our clinics are Department of Health, as opposed to being licensed by Office of Mental Health or by OASAS. So we may want to provide treatment in our Cobleskill clinic, but we may not be able to even get reimbursement to have a counselor in that clinic who can provide the supportive treatment to help somebody change their life and change their lifestyle. That's regulatory reform that we desperately need. I think I'll stop here.
Those are good points for us. I wanted to call on Chief Covert. I know you've been, I've been reading about and hearing about, you've implemented a rather innovative program there in Cooperstown. And if you could describe briefly your experience, and particularly in obtaining treatment options for those who show up at your door and say, I would like to get into treatment.
Well, one of the things with the Perry program, it was started in Gloucester, Massachusetts by Chief Campanella, who had people dying from overdoses, and he didn't know what to do with it. So he reached out to his friends and constituents, and they came up with this program, and then he reached out to the medical community and rehab centers throughout the United States to say, what can we do? One of the things that we have in New York State is most of the people that I deal with say that they have insurance. And they proudly say, I have Medicaid, I have Fidelis. That doesn't do anything for us. It doesn't work for out-of-state. It doesn't work for in-state. In-state, if you have a broken arm, for example, you get it put into a cast and you have it for 6 to 8 weeks in a cast till it heals. The brain takes a long time to heal from this disease. And one of the things that we're doing is we're having these detox centers or rehab centers in New York State that only treat people at the most 14 days to 28 days. And that's after failing several times. It's not long enough for them to heal, so they relapse and they continue the program again. A lot of it takes 4 to 7 days just to get an appointment, and then when your appointment comes, you go to outpatient and you get treated there for a half-hour visit, $50 copay, and you go home. Come back in 2 weeks. The problem is that when we do that, it just doesn't work with the program because it takes so long to heal. We need more programs, more facilities in New York State that are willing to take other things. We need to have Medicaid step up to the plate possibly and provide real insurance. If you have a heart attack, you go to the emergency room, they send you to ICU, they take you down to critical care unit, down to the medical floor, ship you to rehab at Sunnyview or some other place, and then after 2 weeks out there or 3 weeks out there or a month, then they ship you back to outpatient, and after a year they declare that you're cured. You can stop taking your Plavix and everything else. With outpatient, you go in there with a disease such as an overdose, you go, in our case here with Bassett, we go to the emergency room, crisis, released, 4 to 7 days, you may get an appointment, and then you are an outpatient. If you fail the outpatient, you fail again at outpatient, you fail again, you may have come back to crisis 2 or 3 times and been dealt with there again. And then finally they'll say, okay, well you can take 14 days rehab or 28 days, but it's still not enough. The program that we started, the Perry program, we have over 253 rehab centers throughout the United States that we can draw from. I've used just few of them, but they're in almost every state, I believe 40 states total. And with that, we can turn around and contact a placement coordinator who not only looks at them, as an example, I have to back up for a second. When I talk to a person that calls me, the window of opportunity is that moment when he calls me. To have a drug addict call a police chief and tell him I have a drug problem and need help goes against everything that they've ever known. They're paranoid, they're schizophrenic, they're worried about the police, and when they call me, you know that they're at the bottom where they need help. If I leave a phone message and don't come back to it till the next day, I lose that person. They never call back. They never answer their cell phone, and it's done. I've called 6 of them so far all week long that had left messages when I was out sick, and I can't get a hold of them. With this, if we can turn around and get those people the help that they need when they need it, these placement coordinators drop Medicaid, they get Obamacare in other states such as Arizona, Florida, California, and they pay for that. They call the families and they ask the families to pay for those monthly payments of insurance, and then they get them shipped out there. It's a one-way ticket. They fly out to California, they fly down to Florida, they go to the rehab center and it picks them up right at the airport, and they take them there. The cost without insurance is roughly $29,800 a month on average. With that, I've gotten where I have clinics that will dual diagnose people, because most of the people I ask in interviews when I talk to these people, what's your drug of choice? They tell me reluctantly heroin or opiates. And then when I ask them, I said, how long have you been doing this? They'll tell me how many years. I ask them how much they're using so I can get an idea of how much we're taking off the street for the demand. And then in the process of that, I asked them, I said, well, what started you on heroin? Out of the 43 people that I've dealt with so far that are in the program, only 2 of them started heroin right off the bat and said, let's do heroin. One was on his 21st birthday. He did it with 5 of his friends. 3 of his friends are now deceased from overdoses, and he asked for help. But the rest all started from opiates as painkillers administered by hospitals for injuries that they attained back when they were 13, 14, 15, 16 years of age. And that it continued through that process that once the medicine stopped, they weren't able to afford buying it on the street because of iStop, which was a great program. They can't get fake prescriptions anymore. They can't buy pills on the street because they're too expensive. When you can buy heroin in our area is $25 a packet. Down in Newburgh area is $15 a packet. And down in Woodstock, I was getting people there that were buying for $10 a packet. All right, so the commodity is out there that's cheaper than buying pills. And at first they would snort it, and then finally when the drug didn't work for them anymore, they started injecting. Some of my people are using 25 packs a day. If you think of that as even $20 a packet, that's $500 a day times 7 days a week. That's $3,500 a week that they're stealing from the community or stealing from their family, their friends. Life savings are being taken away from the families when you hear the backstories and the horror stories. And the family, I have angels that come into this program that I use as volunteers, and I had 10 of them came right in and said, we want to volunteer, we want to help. But I found out that the family members wanted to help. They have a loss that they don't know what to do anymore. And when they come in, they whisper about this. It's not about, can I talk to you privately? And they start talking about heroin. And I talk to them out loud about heroin, and they look at me and say, oh my God, I've never talked about this before. It's a skeleton in their closet, and when you look at it, everybody has skeletons in their closet. It's just a matter of how big your closet is. And with that, we all know addicts, but we don't talk about it. So I started my program on Thanksgiving because I wanted it when all the family members were sitting around the table at Uncle Jim's house, and Sally, Cousin Sally's in her bedroom. Well, where's Cousin Sally? Everybody in the room knows that Cousin Sally's an addict, but nobody talks about it. Oh, she's in her bedroom. She doesn't feel good today because she's in there shooting up. And with that, I wanted the families to talk because Grandma and Grandpa can afford to pay for the insurance. They can pay for the flight to get out there. And if they can't afford it and they can't pay for it, they can at least talk to them and say a thing like, first of all, I try and get them out of state here when they go to this program because I get them away from their frenemies. And I use the term frenemies because they're friends and family that enable them, look the other way, don't tell them that it's wrong to do this, don't say no, or they're enemies who turn around and keep trying to give them the drug. So I try and send them out of state. In upstate New York, if you're going to start your life over, my choice of going to a place to start over would be a place where I wake up every day and it's sunny. So I send them to California and I send them to Florida. They have the most rehab centers that are available with open beds. I talked to one yesterday. He had 10 beds available out of 14 that he has in his place. They're residential centers. They're set in residential areas in Florida, California. I had a girl call me up the next day after she was sent out to Florida or to California. She woke up on Laguna Beach. And she looked out and she goes, my God, this is beautiful. I'm on the ocean. Her neighbor was a movie star. And she was amazed that she was placed there and that we could actually get her there and get her some help. It takes a long time for these people to heal, so we can't do 30-day stints of this. It doesn't work. I'm trying to get most of the people in 95-day, 90-day stints with 90-day outpatient. And I do that out there and they pay for the insurances. The hang-ups that we have is not having money. Let's face it, addicts don't have jobs for the most part. Addicts don't have money. They don't have insurance. Yes, they get Medicaid because they work with the county and in the county systems, so everybody gets Medicaid. It doesn't help. With that, the last thing is that if we could get more places in New York, get more funding with Medicaid to open up that door for funding, I think that we could solve a lot of the problems here. Our hospitals, our hands are tied. I dealt with the subject yesterday at Bassett, morphine pills, and he's there. He asked for help, but yet he gets admitted. First thing was we were going to arrest him because we had so many drugs on him. We found his prescriptions, and if we admit the person, there's not much they can do other than find a place to place them. That's the sad part, because people want to stay home. They don't want to leave, and we can't do that in New York State.
Chief, just briefly, you mentioned there are 350 treatment centers?
253.
253. Are any of those in New York State? I know you like to go for this more sunshine.
Two of them, right? Two. Both want insurance, so they have to have PPO insurance.
Mm-hmm. And these Florida, California, Arizona facilities, are they privately?
They're privately owned. And if you have PPO insurance, like Blue Cross, Blue Shield, whatever, I can get them there within 24 hours. If they have to get insurance, it's either the 1st of the month or the 15th of the month to get them their insurance so that they become, quote unquote, residents of that state. They get rid of their Medicaid and they take on Obamacare, which those states allow it for rehab.
I see.
So we have nobody in network.
Nobody.
Well, they deliberately use the out-of-network benefits. So if they were in network in a New York State provider, they would get $100. They're getting $650 for that same service.
So
they're going through the back door to go into through the out-of-network.
Point, they're not allowed to be. They don't want to be a provider.
Right.
So we have no New York State providers.
Yes,
Exactly. And that's our problem.
And just to speak to the bed availability, the governor rolled it out. I went on. There were 6 male beds at Conifer Park in the morning, and they were taken within a half an hour. And that was just, and I just looked in Schenectady to Albany. And there were like 1 or 2 other beds available.
And that's if the providers update the system.
Right.
Has anybody found that problematic? It's been a topic of discussion in my district with some people providing services that the new clearinghouse is not being kept up to date, and the information provided is not accurate. Has anybody had any dealings with that?
I'm also getting feedback that it's not very user-friendly. I think right now it's done by county, and I think it would be more useful if it was done by zip code. And also we're able to narrow in on what type of bed you were looking for. And it's a little difficult to find. It's on the Department of Health website. I think the easier access and a little more friendly use would be a good update.
I hear mixed information about the bed availability across the state. I often hear that there are beds open, and that quite frankly we have providers across the state who are at risk financially because they're not operating at full capacity. We're in Shenango County, and by the way, we're not part of the Bassett DISRIP. We're part of Care Compass, which is led by UHS, and unfortunately they did not choose to focus on substance abuse. They chose only to really focus on the mental health in their projects. But I'm told that New Horizons, which is operated out of UHS, inpatient, which we do refer a lot of folks to, is operating generally at a 60% capacity. So I understand, and getting people into treatment during that particular window of opportunity, absolutely. And I share the same concerns that Sue expressed earlier. How is it possible that folks can, have access in such an expedient manner compared to going through the traditional treatment provider system that we have set up? Something is really wrong, and something needs to be fixed. On the other hand, we have to look at how are we supporting those providers that do exist in the state. And if we really are setting up a system where they cannot operate business, then we're going to see more and more of them go away. Because most businesses can't continually operate with a deficit like that. So I'm gonna kind of take an opportunity now to talk about some things that we've already talked about. But I started out by saying this needs to be a multi-prong approach, and the first order of business is prevention. And I think we have to be willing to step back and look at our communities and ask those questions. How well are we doing in terms of growing healthy people? How well are we doing in terms of growing healthy children, supporting families, making sure that families have what they need, the resources they need, so that there is some connective tissue within the community, so that when problems do come up, and they will come up, that there will be those built-in protective factors that will allow families and children and people to remain healthy. And then we've got to be able to address those situations where people desperately need help. And certainly the heroin epidemic is an example of that. And it needs to be now. So, and it's about keeping people alive. That's how small that window of opportunity is. And so once we navigate all the quagmire of how do we keep people alive and how do we access treatment, then we're not done. We have to also then consider what kind of community is that individual returning to. And that individual isn't like operating in a vacuum. They have friends, they have families, they often have children, and all of that has to be considered. When you look at the environments that an addict who has probably been in and out of the jail multiple times, in and out of inpatient rehab multiple times for a number of the reasons that we've already talked about. So they're coming back to the community, and where can they live? What resources exist? We need safe and sober, clean housing options for individuals that are coming out of these very expensive, high-level, high-end inpatient settings. And then we need to, as communities, have roads to recovery. You know how hard it is for an addict to get a job? Do you know how hard it is when they go in and they apply for employment, when they finally get to that point in their recovery where they're ready to invest in some type of job or vocational? It's very difficult. We then create all sorts of barriers for them. So even if the addict is able to get from getting off the streets, getting off the drugs, going through treatment, coming back out into the community, in some ways they're just starting in terms of recovery. So I think we have to look micro at all the moving parts, and we also have to not lose sight of the bigger picture. And I believe government has a role in this, but don't think for a second that government is going to fix all this, or should they? This requires a collective action and what's sometimes called the neglected or collective impact model. Everybody has skin in the game. Everybody has a part in the solution here.